Okay, so my name's Ken Nischal. I'm based at Children's Hospital of Pittsburgh, UPMC, in Pittsburgh, USA. And let's have this journey today about vernal keratoconjunctivitis, which I think is a really important condition that we need to talk about. So let me see if I can get there we go. So these are my disclosures. The only one that might be relevant is Santen. I've given some lectures for Santen for one of their products, but I think you'll find that there really is no conflict there. So before we start, let's start with the poll question. Vernal keratoconjunctivitis is, number one, only due to a type 1 hypersensitivity reaction, true or false? Number two, due to a combination of type 1 and type 4 hypersensitivity reaction, true or false? Number three, T helper cells play a crucial role in the pathophysiology of VKC, true or false? Or number four, none of the above, true or false? So if you could answer that, and then we'll look and see what the audience results are. Here we go. So is only due to a type 1 hypersensitivity reaction. So 30% of people almost said that was true. Due to a combination of type 1 and type 4, 84% that said that was true. T helper cells play a crucial role in the pathophysiology, so the majority said that was true. And number four, the majority said that was false. Okay, so what we're going to do is I'm going to give you the information, and then what we'll do is we'll go through the results and see how you did. So what is vernal keratoconjunctivitis? To understand that, we need to understand the whole range of allergic eye disease. What I want to point out right now is that giant papillary conjunctivitis, right at the bottom of that list, is a foreign body response to contact lens wear. So we're not going to discuss that, but we are going to discuss the other types of allergic eye disease. Now, what basically happens in a type 1 hypersensitivity reaction is that an antigen-presenting cell is hit by an antigen. It then sensitizes a T helper cell. And so when that antigen is exposed again to the body, the T helper cell recruits basophils, eosinophils, and mast cells, and that's what you call your acute allergic reaction. It's a type 1 sensitivity reaction, early phase at 20 minutes, late phase around 6 hours. So this is the type of acute allergic conjunctivitis. We've all seen it. You get inoculation, you get chemosis, swelling of the lids, and conjunctivitis, and that can occur at any age. Seasonal allergic conjunctivitis between the ages of 10 to 40 years, caused by seasonal allergens like pollen, it's hay fever, you get the same conjunctival injection, and you get a papillary reaction. Acute allergic and seasonal allergic conjunctivitis are pure type 1 hypersensitivity reactions. However, vernal and atopic keratoconjunctivitis are more chronic and severe, and more of a type 1 and type 4 hypersensitivity reactions are involved. Conjunctival biopsies show massive infiltration of eosinophils and T cells, mainly in VKC, in vernal keratoconjunctivitis. So here is the pathophysiology of VKC. They play T helper cells play a crucial role in conjunctival infiltration of eosinophils, and it's much more of a chronic condition. So going back to the poll question, VKC is not only due to type 1 sensitivity reaction, so that's false. Number two, it is due to a combination of 1 and 4. And number three, T helper cells do play a crucial role. And number four, of course, none of the above is false. So that was our first poll question. Let's talk a bit about VKC. Onset normally under the age of 10 years, boys more than girls. You get these giant papillae, as you can see here, and they get a thick, ropey discharge. When you look at the epidemiology and the prevalence, the closer you get to the equator, the higher the prevalence. So that's an important consideration. There are going to be people listening to this webinar in parts of the world where they're seeing a lot of this, and there are people maybe in other parts of the world, in the temperate climates, who are not seeing as much. But the disease is the same disease. the severity and the incidence may be worse the closer you get to the equator. So there are three forms. There's the tarsal form with the giant papillae. There's the limbal form where you get a limbitis, you see a general limbitis, and then you also get Horner-Trantis dots where there's accumulation of eosinophils and immune complex in these little sort of dots that actually stain. Here's a close-up of a Hanna's Trantis dots, Tranter-Horner's dots, as you can see here. And when you look at VKC, the approach to treatment differs according to severity. At least that's how we've approached it so far, right? You've got this grading that was done by Bonini and his group, grade 1, grade 2, where you get more papillae, grade 3, where you got giant papillae, ropey discharge, limbal involvement as well, and then grade 4, where the limbal involvement can be very severe and the tarsal involvement very severe. Now, you do not have to have both tarsal and limbal to be grade 4. You can just have the very severe limbal form to be grade 4. So this sort of, so far, how we've dealt with VKC, we've looked at the severity and said, clinically, the signs indicate how aggressive we're going to be. Now, I'm not going to go through that treatment paradigm right now because we're going to spend a lot of time talking about that later in the talk. So in the majority of cases, it resolves after puberty. And so people think it's benign, but you can get sight loss in 5 to 30% of cases, and that's because of shield ulcers, infectious keratitis, corneal neovascularization, keratoconus, limbal stem cell deficiency, and prolonged use of steroid topical therapy can lead to cataracts and glaucoma. So it's not really a benign condition. And when you look at the risk factors for worse visual outcomes, this was a nice paper from Sacchetti and group, where they looked at 207 patients with VKC, of which 110 had at least 1 year follow-up. And they found that the prognosticators for worse visual outcome were perennial VKC, so there's all year round, limbal VKC, history of a corneal ulcer, severe baseline VKC grade at presentations. That's really important. A child may present, and if they have a severe grade at presentation, they are going to do badly if we are not aggressive about the treatment. Higher recurrences in 1 year of inflammation is also a poor prognosticator, and the lower age at onset. All of this makes sense, but it's important to kind of like put this on a piece of paper sometimes in black and white and understand that. So what happens is that the eosinophils, when they break down, they release growth factors and enzymes and granular proteins, and the proteins are epitheliotoxic, which is why you get the breakdown of the epithelium and a shield ulcer, which is also mechanical, of course. I'm going to show you a picture of that. And then you get the conjunctival remodeling, so you get the papillae and you get that sort of exudate over the papillae and that thick mucoid-looking appearance when you flip the upper lids. So that's giant papillae. This is a giant papillae with that mucoid discharge that I was mentioning just now. And then the vernal keratopathy starts off with this epitheliotoxic stage, and then you get a breakdown, and you also always get this sort of layer or plug in the shield ulcer. And if you see this, you have to remove this. If you don't remove this, the inflammation is just going to eat through that cornea. So, having talked about VKC, let's do poll question number 2. First question: atopic keratoconjunctivitis and vernal keratoconjunctivitis are the same condition. Number 2, atopic keratoconjunctivitis does not occur in children under the age of 18 years. Number 3, eosinophils in conjunctival scrapings are more likely to be seen in cases of VKC rather than AKC. And giant papillae are not seen in AKC. True or false? So again, we're going to give you some seconds to see what you think of those questions. I will answer some of the questions that are coming up, but we'll do that towards the end of the talk. So here we are. Atopic keratoconjunctivitis and VKC are the same condition. The majority got it right. It's false. So we'll go through the answers as we go along, and I'll show you the answers again. AKC does not occur in children. Now, classically, it's not meant to, but I'm going to show you that actually it can occur. It's rare, but it can occur. Eosinophils in conjunctival scrapings are more likely to be seen in VKC. That is true. More likely to be VKC than AKC, and giant papillae are not seen in AKC. So that's interesting. Almost a 50-50 split. They are seen in AKC, which is why sometimes children who have AKC are missed and considered to have VKC. But we'll go through that and hopefully show you what that means. So these slides are courtesy of a very good friend of mine and a world expert on this condition, Dr. Dominique Bremont-Gignac, and I'm using them with her permission and, of course, her acknowledgement. So what you're seeing here is a patient under the age of 18, and what I want you to notice is look at the skin of the lids, right? The skin of the lids is quite classical, and if you look down on this image over here, bottom left, this is called the Denny-Morgan fold. They've got this double fold. And if you look on the flexure areas of the elbows and the knees and the neck, you've got this excoriation. And this is telling you that there is a skin condition involved here. And this is what you see in atopic keratoconjunctivitis. But you also can see the limbitis in this patient. While it's normally said to occur in 30 to 50-year-olds, it can occur in children. They can get shield ulcers. They can get giant papillae, and the shield ulcers can have the plaques, those plugs that I was talking about. So it's important that you recognize that. So if you look at VK, this is a paper that Dominique and I wrote for ophthalmology. The child on your left has VKC. The child on the right has AKC. And the big differentiator is the lid skin, the eyelid skin. Look at how you've got that double fold of Denny-Morgan just here, and how the lids look heavy. You know, the child's trying to open their eyes because there's all this inflammation. Do the characteristic comparison. A VKC occurs younger. There's a male predominance, occurs during the spring months. There's a thick mucoid discharge rather than a watery clear one. There's a moderate incidence of conjunctival scarring where there's a higher one in AKC. Horner-Trantis dots are more common in VKC, are rare in AKC. Corneal neovascularization tends to occur more commonly in AKC, and eosinophils in conjunctival scrapings are more likely in VKC. So what I'm saying is, if you see a child who has all the signs that look like VKC, just step back, look at the child as a whole, look at the skin behind the ears, look at the skin on the flexures of the elbows, and look at the lids. Because if it's AKC, you need to treat the skin as well as the eyes if things are going to get better, and maybe more of a systemic approach would be more helpful. So again, AKC and VKC are not the same condition, but they can share the same signs in the eyes. AKC can occur under the age of 18. Eosinophils are seen more commonly in VKC, and giant papillae can be seen in AKC. Okay, so let's talk a little bit now about therapy, what I call pharmacotherapy. As you know, we've shown that you get release of histamine when you get mast cell breakdown. And so antihistamines, both topical and systemic, can be used. Mast cell stabilizers can be used. Dual action drugs that are both antihistamine and mast cell stabilizers can be used. Now, non-steroidal anti-inflammatory drugs can be used, but please remember that if you have epithelial toxicity already or a shield ulcer, using a non-steroidal anti-inflammatory under those circumstances can occasionally lead to corneal melt. So you really want to stay away from that. Of course, we all know that the mainstay of acute therapy is corticosteroid topical therapy, And then there's these things called immunomodulators, which I'm going to talk about. So here's a slide looking at the therapeutic strategies. And you see the first therapeutic strategy is allergen avoidance. Allergen avoidance. If you know something is going to trigger the allergic reaction, avoid it, right? That's important. It's also important to remember that everything we do after that is going to be trying to prevent the cascade that occurs once the T cell is activated by the antigen presenting cell that's been triggered by the antigen. So we look at all of this slide, and at the end of it, it's a question of how do you block this cascade? And for the most part, you're stabilizing here the mast cell, or you're using steroid to suppress the pathways to the eosinophils and the B cells, or you can use an immunomodulator to try and suppress the T cell activation. So that's essentially in a nutshell what we're trying to do. So antihistamines work on H1, they're H1 receptors and antagonists. There's the first generation. They're usually available in a combination with vasoconstrictors. I don't like to use vasoconstrictors because you get this rebound inflammation. The second generation, rapid onset, short duration. Again, I prefer nowadays to use a dual action drop, but it's important to remember that if a child has other signs like rhinoconjunctivitis or maybe even VKC and AKC without rhinoconjunctivitis, that oral antihistamine may be helpful. And I've given some examples of the ones that may be used. Mast cell stabilizers, exactly how they act is unclear, but they basically reduce mast cell degranulation. And again, depending where you are in the world, if you can get a dual acting one, and these are some of the ones that are available, I think they're better. They're better than ones that are just acting on the mast cells or just acting on the histamine pathway. So the dual acting ones are better. If you can have ones that you can use just once a day, it's obviously better for kids because of compliance. But if you have to use them 3 or 4 times a day, they can also act as a lubricant. So lubrication is important because I showed you that slide with all the punctate epithelial erosions. And you really want to try and lubricate when you've got the eye in a situation where you've got giant papillae. You want to lubricate the eye so you reduce the amount of micro trauma. We've talked about non-steroidal anti-inflammatories, and I've explained when I would try and avoid them. There was a systemic review in 2005, and basically they looked at 27 randomized controlled trials, and they said all the drugs were safe. These are we're talking about up to the non-steroidals, and there was a positive effect after topical therapy independent of class. So that's the good news. If you can only get an antihistamine or you can only get a mast cell stabilizer, it's better than not doing anything. So that's good news. Corticosteroids have an anti-inflammatory action. They inhibit phospholipase A2, and they reduce prostaglandins and leukotrienes, and they inhibit cytokines and the adhesion molecules, and they're good for anti-allergy reactions. Some of them are less intraocular pressure raising potential. So you've got fluorometholone, you've got amyloprednol, remoxilone, but at the end of the day, if you have a steroid response, you have a steroid response. Remember that if you've got epithelial toxicity and erosions, that these drugs, even the less IOP raising potential ones, are still going to have an IOP raising potential. Prednisolone acetate in the acute stage, if you've got big giant papillae, you've got huge limbal involvement, prednisolone acetate is better than the other preparations if you can get a hold of it. The problems with steroids are cataract and glaucoma. This paper from 2019 basically showed that there was a prevalence of steroid-induced glaucoma of 3%. And that's the problem. It's the indiscriminate use of topical steroids without a prescription that puts these children at risk. And the picture here shows a posterior subcapsular lens opacity. So what about these things called calcineurin inhibitors? Calcineurin is a calcium and calmodulin dependent serine threonine protein phosphatase. It activates the T cells of the immune system, but can be blocked by drugs. So you block calcineurin, you block the T cell from being activated. And the two drugs that we have are cyclosporine A. It can be used systemically, but it has sort of fairly severe side effects under those circumstances. It can be used topically, and commercially around the world. There's a 0.05% that's available, and a 0.1% cationic emulsion available. Tacrolimus is available and originally called FK506. It's definitely been shown to be effective in treatment for allergic conjunctivitis, both in case reports and series. It's been used in AKC, where you put it on the lid, skin, and then there's also a topical preparation available for the eyes, not available in the USA, but available in different parts of the world. And so tacrolimus and cyclosporine are indeed calcineurin inhibitors and can be used. And the question really is, sometimes we're afraid to use them early. And I'm hoping that at the end of this talk, you'll see that sometimes maybe it's better to use them earlier. This is a paper by colleagues of mine from the RP Center in India at AIMS. And what they basically showed that this was, if you looked at the different treatment modalities, these are all the different modalities that are being used to treat VKC. It's important, you can see that you've got mast cell stabilizers, topical antihistamines, dual acting agents, topical non-steroidals, corticosteroids, and then the immunomodulators. So they all have side effects. They can cause transient burning, they can cause dry sensation. The trouble with corticosteroids, as we've said, they can cause cataract and they can cause raised intraocular pressure. They can also, if you use them when somebody's got a shield ulcer, even though you have to use them, I understand that, they can predispose to an infectious keratitis. So it's worth thinking about a preservative-free antibiotic at the same time. This is a paper done basically comparing the main symptoms and signs that children with BKC had and young adults. And there was itching, tearing, photophobia, foreign body sensation, hyperemia, that's a red eye, punctate keratitis, ornithrantus dots, and macropapillae, so big papillae, giant papillae. And they looked at the different types of drug and looked at if a block is green, that means it had a positive effect and got rid of the sign or symptom. If it's red, it means it didn't get rid of the sign or symptom. If it's yellow, it sort of was just not bad, but not as good as a green. And oranges, it works a little bit, but not very much. And you can see here that topical mast cell stabilizers essentially, do quite a good job. So do topical antihistamines. If it's gray, it means that there was no information in the studies looked at. Tacrolimus, for some reason, it doesn't seem in this study to be as effective at treating the photophobia and the itching. But you can see cyclosporine seems to be pretty effective in everything except for tearing. So I think that's because cyclosporine, depending on the preparation that you use, can cause burning and a tearing sensation. So again, topical antihistamines, topical mast cell stabilizers, if that's all you've got, they work. Topical steroids work, but again, topical steroids don't necessarily get rid of the tearing. And that may be because there are other eye signs that are already causing a problem, like, punctate epithelial erosions. So the first line of treatment of VKC is allergen avoidance, true or false. The use of topical or periocular steroids should always be avoided in the treatment of VKC, true or false. Topical calcineurin inhibitors in the treatment of VKC include cyclosporine and tacrolimus. Oral antihistamines should not be used in the treatment of VKC, and true or false. And lubricating eye drops are of little value in the management of VKC, true or false. So we give you a few minutes. I can see that the question and answers are getting full, and I am going to answer all of those at the end. I'm glad there's so much interaction. it's such a wonderful thing that we can all communicate with each other through this amazing digital platform that we have. And okay, we've got some answers. The first line of VKC is allergen avoidance. So everybody, the majority of people were listening to me, so we got that correct. Well done. The use of topical or periocular should always be avoided in the treatment. So think about steroid therapy as rescue therapy. Rather than as maintenance therapy, think about it as rescue therapy. So the analogy I would give is somebody jumps in a pool and is drowning, okay? Your rescue therapy is no matter how many clothes you've got on, you jump in and you pull them out, and then you do the resuscitation, right? You would not jump in if they had a lifesaver ring around them, right? Because you wouldn't have to, because their life would be saved until you changed and jumped in and helped them out. But think of steroid therapy as rescue therapy. So you do need to use it if you've got severe disease with a threat to the cornea. Topical calcineurin inhibitors in the treatment of VKC include cyclosporine and tacrolimus. Yes, both of those are calcineurin inhibitors, so the majority got that right. Oral antihistamines should not be used in the treatment. So in a child who has VKC and rhinoconjunctivitis, I always use oral antihistamines, oral ones. If they've got VKC and you've got maximal therapy, but you haven't got access to immunomodulators like cyclosporine or tacrolimus, I would still add oral antihistamine because that may have a positive effect. And lubricating eye drops are of little value. So a lot of you said false. For the reason that I said earlier, if you've got microtrauma and you are giving them steroid and they're a steroid responder, what you want to do is reduce and heal the epithelial erosions, so you use lubrication. So lubrication actually is quite important. It's not of little value. It can be of quite important value if you don't have the other treatments available. Okay. It's also useful to keep them comfortable once you've reduced the severity of the disease. Okay. So treatment of VKC, avoidance of allergens and triggering factors, frequent hand and face washing, because you'll get them on your hands, cold compresses, and tear substitutes. So that's lubrication can ease and help symptoms in mild disease. Topical antihistamines, they don't fully address the immune processes, and topical steroids are generally used in moderate to severe cases. Compounded cyclosporine formulations have been used for decades, but they can be stingy. And tacrolimus has been used with good results too. So the commercially available cyclosporine has been used, and there's this study called the Vector study where the 0.1% cationic emulsion was shown to be very effective and actually saved children from needing rescue therapy with steroids. So that's an important study. If you haven't read it, pull it out, read it. It's very helpful. So let's talk about the shield ulcer. So you have a situation here where you have a shield ulcer, you've got giant papillae in one eye, not the other eye. Often it's quite asymmetric. Now, under those circumstances, what I like to do is use a supratarsal steroid injection. I avert the upper lid. Now you can use the first time just a short-acting betamethasone or dexamethasone, or you can do a mix of triamcinolone 0.5 mils and either betamethasone or dexamethasone 0.5 mils. Use a 27 gauge needle or a 25 gauge needle, and I'm going to show you how this is done. Let's have a look here. If you use the short and intermediate acting steroids, they have similar efficacy, but the long acting will really help you control. Raised IOP is uncommon unless the child already has raised IOP because of the topical steroids you were using, and you can get a recurrence in 3 to 5 months, but that buys you time. So here's a child, shield ulcer on the left eye. These pictures are courtesy of one of my ex-fellows, Dr. Ines Wong from Singapore. And you do the steroid injection, and there you go. 3.5 weeks later, it's gone. It's gone. if you use triamcinolone in a child who is darkly pigmented, you have to be careful because it can sometimes cause some depigmentation. I apologize. So you have to be careful. Now, if they're very severe and you think you don't have time, you can use surgical excision with autologous conjunctival graft or amniotic membrane. People have described using cryotherapy and intraoperative mitomycin, carbon dioxide laser. I haven't done those. I've never had to do those. But if you have an ulcer, you've got to take that plaque away. And sometimes you have to do a superficial keratectomy. Some people have used excimer laser. I don't. You might have to use an amniotic membrane transplant or just even a bandaged contact lens. So we've done the answers to the poll question number 3. So for the sake of time, I'm not going to go over that again. So poll question number 4, complications of prolonged use of topical steroid with or without medical supervision. Normally without medical supervision, it has to be said, are cataract, true or false, glaucoma, true or false, keratoconus, true or false, retinal detachment, true or false, or corneal scarring. So we're going to give you a few more minutes again. Let's see what the answers are. So cataract, true. Glaucoma, true. Well done. Now, the complications of prolonged use of topical steroid without medical supervision include keratoconus. That's false. The keratoconus comes from eye rubbing, not from the steroid use. Complications of prolonged use of topical steroid without medical supervision include retinal detachment. Again, that's false because the retinal detachment either comes from persistent, normally from persistent rubbing, it's that deformation of the eyeball. And then the last one, corneal scarring, doesn't come from actually, you know what? That's an interesting question. The corneal scarring could come if they get infectious keratitis, so that could be true. But the reason why I put that there, the commonest cause of corneal scarring in BKC is from a shield ulcer. So that's not from the steroid drop. But you know what? I'm going to say that was a bad question. So it could be true or it could be false. So there you go. Let's move on to the next. So I'm going to show you a case. 11-year-old boy, 2-year history of allergic conjunctivitis, treated by the general practitioner with steroid-containing drops, not seen by an eye care professional, presents to the emergency room with blurring of vision. Vision is 2200 or 660 in the right eye, that's 1 logMAR, and about 2040 or 612 in the left eye. His pressures are running at 50 and 52. Oh my goodness. And look at this. This is his field. What a disaster. This is what he's been treated on. What would you do now? You're not controlling his glaucoma. He's got steroid-induced glaucoma. He had to have trabeculectomies. He had to have cataract operations. We got his vision to 20/30 or 6/9 in both eyes, pressure controlled. But look at that. This child is now stuck for the rest of his life with a poor visual field. He's not going to be able to drive. So remember, the complications of corneal of VKC, not steroids, are corneal scar. Steroids are cataract and glaucoma. Keratoconus and retinal detachment are due to eye rubbing. And here you can see the keratoconus in a child with VKC. So we've been through those answers again. Let's move on. Where are we in 2021? Recent studies show that we need a greater awareness among clinicians for early diagnosis and treatment and to prevent potential sight-threatening complications. And this paper by Wadhwani showed that a total of 70% of caregivers were not aware of the symptoms of the disease. 70%. And 83% were not aware of the side effects of the eye drops used. This needs to change. As caregivers, we need to spread the message amongst our non-eye care professionals about the dangers of steroids and how we need to be more, active and proactive in controlling what's being given to these children. So let's go to poll question, the last one. The quality of life perceived by children suffering from VKC is, number one, independent of the severity of the clinical signs seen by the provider or physician. Number two, is worse than that of children hospitalized for a chronic systemic illness. Number three, is not something physician or providers need to worry about. Number four, impossible to measure. Number five, affected by a child's ability to play outdoors, go swimming, meet friends. So their quality of life is affected by all of those activities in number five. So this time, give me your answers, and then what we'll do is we'll go through and talk about this, and I'll give the answers at the end of that particular session. The questions are mounting up. I'm hoping that some of what I'm saying is being answered as we go along. But those that are not, we will definitely answer. So here we go. The majority of you said that was false, independent of the severity. Good. Is worse than that of, some people are saying that's true. Is not something physicians need to worry about. The majority is saying false, I'm glad. Is impossible to measure. Majority is saying that's false, and is affected by a child's ability to, and that, but a lot of people are saying that's true. So that you guys are pretty much on it. Let's see what we say. So health-related quality of life, this is something I want you all to start thinking about. It's a clinical objective evaluation of signs and symptoms commonly which are used to evaluate VKC severity. They may not reflect the impact of the disease on the patient's health-related quality of life. In other words, the clinical objectives of the signs and symptoms may not be related to the health quality that the child perceives. So this is one quality of life questionnaire developed by Bonini's group. This is how they did it. It's a good paper to read, and I don't want to go into the details of it yet, right now. But what I want you to look at is that when they looked at the percentage of children referred with VKC-related symptoms, the majority of children had problems with common things that children do. They had problems going to swimming pool, problem practicing sports, problems meeting their friends, problems playing outdoors. This is things that children do. Now, in this particular survey, they had this quick method, what they called a quick survey, and it was significantly related to clinical symptoms and score related to the disease process. But when you tried to relate that score to the activities, there was a lack of correlation. That's because children tend to get on with things, you know, they just don't complain as much as adults do. And the parents also, you know, made the children do things, even though the children felt that they couldn't do them as well as they wanted to. So bear that in mind. This is another quality of life questionnaire. It's an important one. And what this one shows, it looks at all these different activities, and they compare those to children who had other issues. So children who are hospitalized, children who had VKC, children who had chronic illness but not VKC. And what they found was the scores in most of the domains of individuals affected by VKC were even lower than those qualified by children with chronic illnesses, and even those that were hospitalized. So think about that. These are children with VKC, and their quality of life scores were lower than children who are hospitalized for chronic illness. So this is kind of important. This other quality of life questionnaire shows that the presence of active severe VKC was not associated with a worse quality of life. So you can have severe disease. The quality of life doesn't necessarily mean it's terrible, but here's the flip side. You can have what you think is mild disease clinically, and the quality of life is significantly affected. And what they used was these visual analog scores for four symptoms or symptoms, and they did an aggregate of the four VKC symptoms and looked at how the symptoms related to the severity of the disease that the clinician saw objectively. I think the important thing here is that just because the signs you see are mild, the effect on the quality of life may be quite great. So I'm going to look at this again and say, just because you might have a mild to moderate disease doesn't mean that that child's quality of life is not being severely impacted. And in fact, you know, the quick questionnaire was used to assess the health-related quality of life in the vector study that I mentioned. And what they found was that cyclosporine actually improved the quality of life in all the domains in that study. So again, suggesting that we need to perhaps change how we approach dealing with VKC. So the quality of life perceived by children suffering with VKC is independent of the severity of the clinical signs. That's true. Is worse than children hospitalized for a chronic systemic disease. That's true. It is something we should worry about. It's not something we can afford not to worry about. It is possible to measure, and it affects the child's ability to play outdoors, go swimming, meet friends. So important consideration. So in the last part of the talk, the last 5 minutes, what I want to talk about, and it's important, is how people are changing the way that they are approaching VKC management. You know, avoid the allergy triggers. Make sure you're dealing with VKC versus AKC, because AKC you're going to treat the skin with at least topical tacrolimus, maybe systemic therapy, get the dermatologist involved, and you need a multi-pronged pharmacological approach. The goals are different, right? The goals should be that there's an awareness of the long duration of the disease, schedule the visits with the patient before the offending time of the year comes along, and let's be preventative. Let's not be reactive. So with that thought, there are several tailored approaches to the treatment of VKC, one from Bernini that's worth reading. You know, this is, again, the child that I showed you before. Here is the different severity scales, and this is how we have approached things before about, you know, it gets severe, so you get more severe in your therapy. But, you know, maybe we should look at the number of recurrences per year and say, actually, there might be mild or moderate recurrences, but you've got more than 2 or 3, you're getting 2 or 3 a year. That's high risk. That's not low risk. Look at the presence of ocular symptoms, and then look at the signs, put that together, and then grade the severity. This is a nice paper from Jode Mehta and Dominique Bremond and their group. And basically, it's a busy slide. What they're showing is that the new paradigm should be that you intervene earlier with the non-steroid drugs like the immunomodulators, or you do rescue earlier for a shorter time with steroids before you stabilize, rather than wait for things to get worse. And this is a paper that's worth reading, because they look at all these different issues, and they look at the different interventions that you can make. And again, from the United Kingdom, they again are suggesting that while we've always looked for disease to get severe, and we've looked at disease signs, let's look at the symptoms. Let's look at, can we avoid surgery? Can we get in there earlier so that we are trying to stabilize these children better? And I'm going to talk about that in a second. So there's a paradigm shift, right? Avoid surgical intervention, avoid prolonged or recurrent use of topical steroid, improve the quality of life, consider the age of onset and multiple recurrences as an indicator of disease severity, consider effect on daily living as a severe disease, and when do you use the use of calcineurin inhibitors as the natural choice? Tacrolimus and cyclosporine are available. I know they're available all over the world. Sometimes you have to compound cyclosporine. Now there's commercially available cyclosporine, but we need to approach that. Now look, this is a protocol that I've developed with my team at Children's Hospital of Pittsburgh. If you would like a copy, this is too busy to go through right now. It just goes through everything we've talked about. But if you'd like a copy, please email me at ken.nischal@wsqs.org, and tweet me at NischalKK. let's start a conversation. So on that note, I want to say thank you so much for listening. And I think, if I'm not mistaken, we have some time for questions. Can I go ahead, Cybersight team? Can I go ahead and answer some questions? Okay. So let's start with question. Let's start the question number one. Mortazavi Fard. Hi, thank you for listening. How often are family history and hereditary factors responsible for VKC? That's a really good question. If you have a parent who's had allergic conjunctivitis, the chances are that their children may get allergic conjunctivitis, but it's multifactorial. So it's not just a family history. There's often the exposure to allergen that is a question that needs to be answered. So yes, that's a good question to ask them. How do you differentiate perennial VKC from atopic? So the main difference is skin. You've got to look at the skin to help you figure out what's going on. So I'm just going to move that across here. Is skin atopy necessary? Yes. Those skin changes are necessary unless a dermatologist tells you that there's something else going on in the body that makes you consider AKC. But as an ophthalmologist, that's what you want to look for. May I ask, since many are long-term diseases, and especially children, shouldn't we avoid steroids? Yeah, we should avoid steroids long-term. So this is what you do. You can, depending on what you have, you use antihistamine topically, anti-mast cell stabilizer, or a dual-acting, for sure, keep using those. Oral antihistamine, use the steroid lubricant, use the steroid for rescue, use supratarsal steroid injection or subconjunctival around the bulba if you have limbitis, but then try to see if you can use a calcineurin inhibitor to try and get off the steroids, right? That's what I would do. How early should we treat this aggressively? Early. If you get a 4-year-old who's got terrible limbitis, treat it aggressively. Oral antihistamines, dual-acting, topical drops, lubrication, supratarsal steroid injection if the papillae are big, supratarsal steroid injection if you've got very big limbitis, affecting a lot of the limbus. Treat it early. Treat it early. I use oral antihistamines in those circumstances. So Karina Prativi was the answer. That was the question of that. What about environmental measures and living habits modification? Absolutely. Avoid allergens. That's the first thing that you have to do. Avoid allergens. Cyclosporine is effective. Side effects is tolerable. Yes, I agree. Totally agree with you. How young? Okay, that's a good question. I've not used cyclosporine in children under the age of 4. I have used tacrolimus in children who are 3 years old, but that's been on the skin. So there's a little trick. You can use the skin ointment, use it right on the skin here and right at the edge, and a little bit will leak in. Do not put the skin ointment in the eye. It burns. It burns. How many times should one repeat? Oh, good question. So if you're using a long-acting, you can get 3 to 5 months. But remember, the idea is it's steroid rescue, right? Once you get the tarsal plate quiet, and the papillae are gone, you've got to use everything else we've talked about: oral antihistamines, topical, dual-acting if you've got them, and the calcineurin inhibitors. So that's what you've got to try and do. It's a rescue. It's a rescue. If a patient has a fasciitis with jump, excellent question. Numero uno, if there's a plaque, take the child into the OR. If because most children won't let you do it in the slit lamp, take that plaque off. Give the supratarsal steroid injection. That's the thing you want to do with immediate acting. If they've never had steroids, use immediate acting, only 1 ml. It's important to do that. In fact, I did one just the other day, and I think that's the way you treat it. Lots of lubrication, oral antihistamines, throw everything at them, and then you start the calcineurin inhibitors, right? How can we really avoid anti-allergological, I can't say that word, test should be required? You know, if you have an allergy specialist, then yes, it's worth doing and worth getting. That's worth. Not everybody can do that. So you have to speak to the parents, take a history, get your nurse to take the history, and find out exactly what you can do. How can you reduce recurrences? Using a calcineurin inhibitor that will prevent the recurrences from occurring. Now, you might not have to use it all the year round. You know, use oral antihistamines. There may be the offending times of the year. If it's perennial, then you have to see if you can reduce the dose of the calcineurin inhibitor, or oral antihistamines are safe. Topical dual acting are safe. You can use those all the time, but that's the only way you can do that. Can I use topical for external use instead of ophthalmic in countries? So that's what I'm saying. Don't put it in the eye. Just put it on the skin here, and I have found that a little bit leaks into the eye, and that works. For how long can we use topical steroid? Topical steroid should become a rescue mechanism. It rescues and then allows you to stabilize. So I would not use steroid long-term. Now, there are going to be parts of the world where it's too expensive. You can't get a hold of cyclosporine or tacrolimus. Under those circumstances, go from the strong-acting prednisolone acetate to something like FML. Now, remember, FML is fluorometholone. If you have fluoride in the molecule, it's hydrophilic, can't penetrate the hydrophobic corneal membrane. So use FML, but try and use it when the epithelial surface is intact. So lots of lubrication. How long does vernal? So VKC can cause blindness. That's what I said. You know, 5 to 30% of studies have shown. 5 to 30% of patients in studies have shown that you can lose vision because of the complications that we've talked about. And VKC can last years. Normally, you grow out of it, but you can. Now, there's a suggestion that you can get VKC for the first time in young adults. That's a whole different story. Can you use methyl? I've never used methylprednisolone as a supratarsal. You need to speak to your pharmacy and check if that's safe to do. How do we abstain from allergens and that's a great question. Look, getting them to wash their hands regularly, using a cold cloth, wet cloth, but one that's clean, because you often see children using the same dirty cloth on their eyes. You know, that vasoconstricts, that helps. That's the best I can advise. Maybe so even sunglasses, you know, so that it sort of acts as a barrier. What about vitamin D? That's a good question. So somebody asked me this the other day. I don't know if the vitamin D deficiency story is causative or coincidental. So I don't know. But you know, if you're vitamin D deficient, you need vitamin D in any case. What happens to the eyes is secondary. You need vitamin D. How about changing location? Well, I have known families that have moved because the effect has been so severe on their children. So it is an option, but it's, you know, not everybody can move. They may not be able to get a job. Any contraindication of using contact lenses? Look, if you have contact lens, so using bandaged contact lenses to temporize when you've got big giant papillae and you've got an ulcer, you can do that. But you've got to get the child to the OR to get rid of the plaque on the shield ulcer. So yes, you can do that. It's not a contraindication, but you've got to cover it with preservative-free antibiotics. What is the ocular treatment for atopic? It's the same. The ocular features are treated the same as VKC, but you have to treat the tacrolimus. You have to get someone to treat the skin disease. How long should acute VKC be placed? Or you treat them. You treat them until you've got the disease under control. Then you try and use something else. if you've got it. And if you haven't got something else, like tacrolimus or cyclosporine, then use some of the, I like to use FML, as long as the ocular surface is intact. Excellent class. I like you, Maria, very much. Thank you very much. Is there any difference, between the developing versus developed? Well, there is, because access to commercially available cyclosporine, commercially available tacrolimus in the developed world is easier, and there are insurances that cover it. There's nationalized health that can cover it. So there is a difference. But the point is, organizations like Orbis, organizations like the World Society of Pediatric Ophthalmology and Strabismus, we're raising the awareness. We're going to governments and trying to make sure that we get access for these drugs to the countries that need it the most. Can AKC be treated without its no, AKC is a chronic disease. It's not like it's a recurrence. You can control the disease in the eye as a recurrence, but you've got to treat it. What do you think about people who use antibiotic ointment? The problem is that's preservative in it, right? You can, if you have to use an ointment to lubricate, okay, you've got to balance the risks, but you've got preservative in it. Role of immunity, yes. If it's really severe, I've given oral steroids when I haven't been able to get the child to the OR. You can give a short course of tapering oral steroid, 1 milligram per kilogram, reduced by, so let's say the child weighs 20 kilograms. You give 20 milligrams for 4 days once daily, then 15 for 4 days once daily, 10 for 4 days once daily, 5 for 4 days once daily. Can we inject steroids subconjunctivally instead of, yes. In limbitis, it's got to be vulva. Morteza, thank you so much. Tulika, thank you so much. Thank you so much, everybody. I appreciate. What measure can we take to treat AKC? Ooh, get rid of the cause of the dermatitis. So you need to get your pediatrician or a dermatologist involved. What measure? And I think we got to the end. Yes, it does. Balchandra Trivedi, yes, prolonged use of steroids affects increased of, yeah, it does. It's a disaster. It's a disaster. So you've got to monitor them. And then you've got to treat the glaucoma and use preservative-free drops. I think we've answered all of them. No, we haven't. Can cyclosporine be given No. I don't know anybody who's done that. Don't do that. I don't know what the reaction would be. What about children temperate where symptoms such as itching become severe with increase in temperature? Would you recommend Yes, I give them photochromic lenses, but you're still got to treat the disease. Karina, thank you. Mawash, I've done my master's in advisor. You've just added the chat. Oh, thank you so much, Mawash. Khan, thank you so much. Thank you, everybody. I appreciate. We all like feedback that's positive or negative so that we can make it better the next time. Yes, steroid use can cause hyperpigmentation of eyelids when you do it topically, but the supratarsal steroid injection, if you use triamcin alone, can cause depigmentation. So be very careful. Mustafa, thank you. Looks like we're supposed to be. Can olopatadine be described? And that's a good question. Look, there are drugs that we use that are off-label. For example, most of the anti-glaucoma therapy that we use in children is off-label. If you're going to use it, tell the parents and monitor. So it's not that you can't use it, but you have to monitor. Thank you, Fabiola. Is it okay to continue dual action drops per? Yes, it is. Tulika, absolutely is. How long can we use lubricants? If they're preservative-free, I say to my parents, use them as often and as long as you like. Marianne Forsberg, thank you. Diana, I understand you came late. I guess Cybersite managers and team, they can access this webinar. I don't know if they can, but they'll let you know. How can we prevent shield ulcer? Look, the way to prevent the shield ulcer is to be aggressive at an earlier stage. But if you get the shield ulcer and they've got a plaque, do not wait. I had a child who unfortunately was referred, they'd waited, that plaque just melted into the cornea. Do not wait. Get into the OR, supratarsal steroid injections, release the plaque, put on a bandage contact lens if you like. Roberta, thank you so much. When you have a patient who is sensitive to steroid showing increased IOP, the same strict severe, how do you proceed with controlling the condition? Anti-glaucoma medication, preservative-free, and acetazolamide. Now, I showed you a case where it was extreme, and I did trabeculectomies because I didn't have at that time cyclosporine or tacrolimus to treat them with. I would treat them with calcineurin inhibitors now as well. Sherry Ann, thank you so much. Can Avastin be used? It can be, but only once you've controlled the disease process. If the disease process is active, using anti-VEGF is a waste of time. It's like blowing in the wind, or, you know, it's a waste of time. You've got to control the disease first. Maggie, thank you. Somta, thank you. Oh, Goram, thank you very much. Chidinma, thank you so much. Everybody, thank you so much. How long use, please? I try to use I try to avoid non-steroidal anti-inflammatories in children. If you have to use them, make sure the ocular surface is intact. But you can use them, when you use them, after 3 months, I'd stop and see how things are going. Do not use them all the time. I don't want to talk about anti-VEGF injections. Maybe Cybersite, we could do another talk on the use of anti-VEGF or corneal diseases in children, because that's a very, very specific subject. And there are lots of pros and cons, and I don't think I could give you a response that is fair at the moment. Rita Gamma, very good friend of mine. Hi, thank you so much. David, Balchandra, Colin, everybody, thank you. Ismail, thank you so much. I think it says we've still got open questions. I thought I'd answered all of them. Oh, here we go. How many times do you prescribe 0.1% cyclosporine? So the cationic emulsion I use 4 times a day, but I have been able to reduce it to twice a day. I've used 0.05% commercially available. It's supposed to be twice a day. I've had to use it 4 times a day. Not as effective as the 0.1% in my experience. If you can get a compounded one of 2%, it stings, but you could get away with twice a day on that and then reduce it to once a day. So how long should acute VKC be placed on? So I think I answered that. Use it as a rescue and then taper it and try and use the less, like FML. I like FML. I have no conflict of interest with FML. I just love using it. I think it's really helpful. Do you consider, there was a question there that said, do you consider blepharotosis a complication of, so good question. If you give the injection too high up or too deep, you can disinsert the levator. So yes, it can be a complication, but it means you've gone too deep. When you give the injection, you should get a balloon of conj coming up. If you don't, you've gone too deep. So it's the technique. Is subtenon steroid injection? You could, but it would be for bulbar disease, you know, for the limbitis, and for that I prefer to use only short acting. Don't use triamcinolone on the bulbar surface because it leaves the white sediment, and that doesn't look nice. You could give a posterior subtenons. I've not done it, but you could. How frequent? So as I said, I tend to give them, I normally get away with giving them once a year if I need them. And that's because with the calcineurin inhibitors, you can control things better. How long can you use cyclosporine? 1 month enough? So normally it is, you can use them. So what I tend to do is try and get them over that, normally the summer months, right? So treat them for a month on 4 times a day and then reduce it to twice a day. And if everything, as they sort of go, and I use that for a couple of months, and then I would stop it, see how things go. The point is, you can't just say to them, see you in 6 months. You've got to review them to see what's going on. So the tacrolimus, children can use that on the skin safely, like once a day for a long time. I've used that, kids have used that for 6 months at a time, and I've not had any problems. So azithromycin is used for blepharokeratoconjunctivitis due to meibomian gland disease, but not in this vernal keratoconjunctivitis, which is allergic, right? In your, yes, it does. It does persist into adulthood. I've seen that, but it's rare. So when is subtarsal steroid combined with an anti? If you have a shield ulcer, I will give a subconjunctival injection of cephalosporin into the bulboconj, but only if I'm worried about the size of the shield ulcer. You can do that, but I don't inject antibiotic into the supratarsal space. It's not subtarsal, it's supratarsal. That's really important to understand. It's above. So here's my tarsal plate. Can they see me, managers, or can they not see me?
Yep, everyone can see you.
So there's my tarsal plate, right? The width of my finger. You're actually injecting just above it, but on the conjunctival surface. So it's not subtarsal, it's supratarsal. It's just that because you flip it, it looks like it's below the tarsus, and it's not, it's supratarsal, which is effective and safe for immunomodulators. If you have acute disease with giant papillae, epithelial toxicity, then the steroid, you've got to use rescue. You've got to use rescue because immunomodulators may take up to 3 weeks to work. So it depends on the condition. Antihistamines treatment in VKC, boy, I've had children on antihistamines orally all year round. So you can speak to the pediatricians. I just have never been told it's a problem. So they use them. Parents tend to stop them in the winter months because they feel that they don't need them. But I've not stopped using them. Any room for prophylactic medication against raised IP in patients deemed to be? So how are they at risk? That's the problem. If we knew somebody was at risk, it would be great, right? Because then you'd go, you're at risk, we're going to see you earlier. You're not at risk, we don't. We don't know. I've never used prophylactic anti-glaucoma medication thinking, yeah, well, now there may be a situation where a child already has glaucoma and then develops VKC. Now you're in a different situation. You may want to up the drops because you're worried that if you give steroids, you're going to make the glaucoma worse. Ever tried? So I have not tried topical interferon. There are papers about topical interferon. There's papers about systemic interferon. But in terms of a drug that's easily available, I don't think it's easily available. And so I can't answer that question. It's okay to use, yes, you can use dual action all the year round. Yes, I have seen patients who don't respond to cyclosporine, very rare. Try and use tacrolimus, even if they don't have AKC, see if you can get a formulation made for ophthalmic use, compounded. And if that doesn't work, then you want to get a pediatrician involved because this child's going to have more than just VKC. They're going to have a systemic allergic issue, not necessarily atopic keratoconjunctivitis, and see if you can use some of the biologics then. Now you're talking about really severe, very rare disease. So you need pediatricians involved in their cases. Steroids, cyclosporine or tacrolimus, which is one. So I'm going to repeat, this is important. If it's the one thing you go away with, if it's a severe VKC with sight-threatening complications imminent of the cornea, hit them with steroid rescue and then you can start the immunomodulators at the same time, but they need steroid rescue, whether that's supratarsal steroid injection or topical, they need it. What about parent counseling? You need to tell them this is a severe disease. You need to tell them that if the child is complaining about not being able to go out, of not being able to play with their friends, they need to tell you this so that you understand that the severity of the disease is greater than the signs that you might be seeing. What about food? Yep, that's a good question. A lot of parents will try and change the diet. I don't think that's a bad thing. Gut inflammation, an underlying cause. I don't think it's an underlying cause. It can be coincidental, but I don't think anybody's proved that it's an underlying cause. When we see AKC in an adult, does it suggest? And he said, well, I mean, you want them evaluated by a general practitioner to make sure that they haven't got any other atopy conditions affecting the gut, especially, but not necessarily otherwise. Can topical be prescribed? Yeah. So that's what I said. Many of the drugs we use topically are not licensed for use in children. So, for example, glaucoma drops. So if you're going to use them under the age of 2, there is no indication or study I know of that suggests that you're going to damage the eyes, but you might want to see them more frequently to make sure that there's no side effect. Does rain cause VKC? That's a good question. I think in parts of the world where you have sulfur rain, where there's a lot of industrialization and perhaps less control on the environmental effect of gases being released, that may be the case, but not otherwise that I'm aware of. So it's to do with the industrial pollution within the air that may be related to rain. In developing, we see ptosis associated with this. So the ptosis is because of all the extra inflammation. It's a mechanical heavy ptosis. Treat the inflammation, get rid of all the kind of accumulation of fluids, and things will get better. Recommendation for cataract surgery in a patient, be careful. The recommendation is be careful for cataract surgery because their zonules, if they're older, can be weaker. So you have to be careful. When you do the rexis, you get an idea of how weak the zonules are. Then I would use iris hook lenses to hook the bag up while you do the phacoemulsification. If it's a child, you don't need phacoemulsification. Do irrigation aspiration. How effective is cold? Yes, cold compresses are effective, but make sure the cloth is clean, your vasoconstricting. Do you use tacrolimus and VKC? No. I mean, you can use, I don't use it, but if tacrolimus is the only calcifurin inhibitor you have, use it. And if it's the skin preparation, use it on the skin, but it'd be better to compound it and have an ophthalmic preparation if it's truly VKC. What is the relation with intestinal parasite? You know what? I have been to in the Middle East where they suggested that intestinal parasite infestation could be related to changes in allergic sensitivity. And I don't know is the answer, but there are those of you in that part of the world where you see a lot of this who I would love to collaborate with. Contact me, ken.nischal@wspos.org. Let's start a study. Let's look at this. What's the highest concentrated? So I have used 0.5% compounded. It stings, but use it if it's all you've got. I've seen 2% used. Which is more effective or safer? Well, I think we've answered that, right? Steroids for rescue and then long-term immunomodulators. If a child is not a steroid responder and you have to monitor them, then yeah, they're kind of safe, but the trouble is you're now predisposing them to cataract and increased risk of topical infection. Does cryotherapy? Well, there are parts of the world where they don't have supratarsal steroid injection, so they'll do cryotherapy to the giant papillae. I don't do it. I think the steroid injection is much better. How fast does the cornea regenerate? If you have a shield ulcer, you take away and control the inflammation, it's fast. I showed you, within 3 weeks, it can disappear. Within 3 or 4 days, the ulcer can disappear. No, it's been my pleasure answering. When do you have, it says, when increased, okay. When you have a patient who is sensitive to steroid showing increased IOP at the same time, do you proceed with controlling? Yes. Yes. You've got to control the condition. You've got to control the glaucoma. And we've answered the avastin question. I mean, it's complicated, but you've got to treat the disease first. 0.1%, I think we've already answered that. That was 4 times a day, but then you can reduce it and try and get off. My pleasure. This is one of the best webinars I've had the pleasure to participate in. Do you recommend corneal topography? Not for every patient. Look, use your clinical signs. Use the direct ophthalmoscope and the retinoscopy to see if you're beginning to get changes that are indicative of keratoconus. If they are, treat the allergy, control the allergy, and get someone to do collagen cross-linking. That's a whole new topic as well. Thank you so much. It's been wonderful. Thank you. So I love the questions. They've been absolutely phenomenal. I don't know if you could share my email again, Cybersite, but please contact me if you have any other questions. Contact Cybersite. It's been a real pleasure. Thank you.